Hello. The mental health diagnosis that I chose to research and further discuss in the DSM-5-TR was bulimia nervosa, known as an eating disorder. Bulimia nervosa is described, or not described, diagnosed in individuals who go through repeated episodes of binge eating, followed by behaviors/actions to avoid weight gain while focusing on body weight and shape. Binge eating is defined as eating in a discrete period of time an amount of food that is definitely larger than most individuals would eat in a similar period of time under similar circumstances. Some of the behaviors/actions that individuals with bulimia nervosa include, but are not limited to, are self-induced vomiting, misuse of laxatives and or diuretics, periods of not eating, and or excessive exercise. Bulimia nervosa is reported to affect 1 to 1.5% of the world population in a 12-month period, and in the US, it affects 0.14% to 0.3% of the population in a 12-month period, with a higher prevalence in women compared to men. What separates bulimia nervosa from other eating disorders is that individuals with bulimia nervosa are typically within a normal weight or overweight range for their age, gender, and height. Individuals who have an increased risk for developing bulimia nervosa are those who experience childhood obesity, went through puberty at an earlier age, or have family members with bulimia nervosa. There was also some studies that I researched that showed specific genetic makeup having a positive correlation to the development of bulimia nervosa, which I thought was very interesting. Treatment options that I explored with bulimia nervosa was cognitive behavioral therapy, family-based therapy, and interpersonal therapy, or interpersonal group therapy. And within all my research that I did for bulimia nervosa, a group that I thought about was those who identify as male, just because a lot of the readings were very woman and female, like, talked about, I guess dominated, where it was like women are the ones that show this, women benefit from this. Like, it rarely talked about male identifying individuals and what interventions they could go or work with, and a lot of the times, like, diagnoses and treatments were always relating to women. Another thing that I learned in reading the literature is how a lot of clinical workers steered away from certain approaches with research-based interventions, just because they think it will trigger the client or drive the client back to remission. So when they'd hear certain, like, stressors, like, they wouldn't want to bring it up again with the patient. Specifically in cognitive behavioral therapy, there was a lot of pushback within the interventions that I noticed, that clinicians wouldn't fully express with their clients, and that was like a negative effect on them, where it then led them to that remission. So yeah, that was my short overview of bulimia nervosa. Thank you.